So thank you for inviting me, but I have to start with thanking my previous speakers for keeping Luke alive, because otherwise my talk would be quite unimportant. So I have no disclosures, but only have one remark. I will be presenting one slide with some data that have been not been published and have been submitted, so I would kindly ask you to not tweet that particular slide, but tweet along everything else if you would like. So, welcome to work. It's Monday morning. You've had this excellent conference, but now you're ready to go to work again. And that can be either in the ED, in the operating theater, or in the ICU. And while you walk into your hospital, you think of all those patients you've seen before, you've saved their lives, you've done heroic things, and you wonder how they are doing. Today you'll be an ICU physician. And if you're not, just pretend to be one. It's not that difficult. And you'll be having a family meeting with two patients, and they're just regular planned family meetings. And the first patient and family you'll be talking to is Anna. And you see Anna there in the back. She's a 36-year-old surgeon. She had presented herself to your ED 6 weeks before with an obstructive gallstone. Unfortunately, that led to a pancreatitis, which led to necrosis, infected necrosis, multiple surgery, multi-organ failure. And she had been in your ICU for, well, let's say 5 weeks now. She is recovering, and you're planning her discharge somewhere next week to the ward. The second patient you'll be talking to is, of course, Luke. He looks a bit different here, but it is Luke. Luke is a, 70-something-year-old male, and you see him walking with a stick, and that's because he suffers from some vascular arterial disease, which led to an amputated foot a couple of years ago. He suffers from some mild emphysema, and he got admitted to the ICU because he fell down the stairs, as you all know. And that fall was because of ventricular fibrillation due to myocardial infarction, but that fall was complicated by multiple fractures and the spleen rupture, which led to hemorrhagic shock as well. And he has been in your ICU for 4 weeks now, had some slow recovery, but you are planning to discharge him to a rehabilitation center in the next coming week. And today you'll be talking to those patients and those families. Of course, not at the same time, but you have two conversations. And while earlier conversations were merely about health status issues, what's going on in the ICU, what are the medications, what to expect, tracheostoma, whatever. Now you plan to talk a little bit more about life after ICU, about regaining an everyday life. So you put on your serious face and you say, well, discharge is the first milestone on your way to recovery. And you will say something as, this is the first hurdle, but there will be many more hurdles along the road. And these patients and families will probably look at you and say, what do you mean? Be a bit more precise. Well, since you've been to Resus and listened to Mark, you can show them and tell them some facts. So you might start with telling them that 10% of the patients will die in the year afterwards. You might. You might tell them that 30% of the patients will be dead in 3 years. You might decide not to share that. But you have to tell them about post-intensive care syndrome. And as Mark just told us, that's defined as new or worsened disabilities in your health that persist after your acute care admission. And it comprises of 3 different groups of symptoms. First is physical. And that means both exercise capacity as activities of daily living. And we know that on average, the exercise capacity is around 60% at both 6 and 12 months after discharge. That means that a lot of patients are not able to increase their exercise capacity after 6 months. Furthermore, 1 in every 4 patients acquires a new functional dependence in one of activity of daily living. That's usually bathing or dressing or continence. Cognitive health. Cognitive health comprises memory, attention, executive functions, mental processing speed. And 1 in every 4 patients will suffer from cognitive impairments comparable to patients suffering from mild dementia 1 year afterwards. And usually when you have some cognitive impairments, it comprises multiple groups. It's both memory and attention. Mental health, that covers depression, anxiety, and post-traumatic stress disorder symptoms. And the incidence differs across studies because of different screening instruments they use. But we presume that about 1 in 3 patients suffer from depressive symptoms and 1 in 5 from post-traumatic stress disorder symptoms. And also for these patients, multiple symptoms are concurrently present in many patients. You also have to tell them that 1 in every 5 patients will have symptoms in 2 or more categories, and 1 in every 20 patients will have symptoms in all 3. So, you've shared all your knowledge with them. Well, they're not happy, but at least they're grateful for your time, and you leave. And while you, on your way home again on that Monday, you just walk over the ICU, and on the left, you see Luke in his bed, being read a story by his grandson. And on the right, you see Anna. She's in her chair, and she's struggling to type something on her iPad. Something doesn't feel right. You have just shared the same facts to these 2 patients and their families. But these 2 patients, they don't look a lot like each other, don't they? So usually as ICU physician, we feel that ICU patients, after about 10 days, they start to look like each other. They all have the same problems. They get aspiration, line infections, things like that. But these 2 patients, they had very different pre-morbid health status. We have the very healthy surgeon, and we had Luke, who already had some comorbidities. So probably their outcome won't be exactly the same. So sure, you know, age affects outcome. Higher age, worse outcome. You also know that the amount of comorbidities will affect outcome. If you have more comorbidities, you have less capacity to recover. You also know that frailty is very important. The more frail a patient is, the worse his or her outcome will be. But apart from these exact differences in outcome, the impact of the disabilities on their outcome, on their lives, will differ majorly. Think of mild cognitive impairments. For Luke, that might mean that he won't be able to cook a very complicated 3-course meal, which he didn't do anyway. But for Anna, that might prevent her to return to her work as a surgeon. So the impact of the same disabilities is very different for your different patients. So they have asked patients, and there are 3 recent studies who did that, what do you feel is relevant when we as ICU or critical care researchers do our long-term outcome studies? And they've included both researchers as well as clinicians, as well as patients and their families when asking them what is relevant. Quality of life, return to work and prior activities, and pain are very important, just as anxiety and depression, physical functioning, and post-traumatic stress disorder symptoms. So if we take this back to our concept of post-intensive care syndrome, we could say that health-related quality of life is kind of an overarching concept. So we have to consider health-related quality of life when we talk to these patients. But these studies also revealed something else that's very important. The questionnaires we use to evaluate health-related quality of life, like the SF-36 or your QOL, your Q5D, they do not cover all relevant aspects of outcome if you ask patients. Moreover, there are symptoms that impact well-being of your patient that are not covered in these questionnaires. So these questionnaires, they leave substantial gaps in what is really important. So maybe our quality of life questionnaires do not really cover how patients value their life. So we might have to look into appraisal. How does a patient values his or her life after critical illness? So in our hospital, I work in Utrecht in the Netherlands. We send questionnaires to our patients 1 year after ICU. So these questionnaires, they comprise of the usual questionnaires used to measure depression, anxiety, quality of life questionnaires. But we also ask patients, do you think your outcome is acceptable? And what we saw is that 5%, only 5% of the patients disagrees with it. They feel their outcome is unacceptable. The largest amount of patients say, I agree, my outcome is acceptable, and there's one group that's neutral. So we try to look into those 5% of patients who thought their outcome was unacceptable. And we could relate that to low quality of life scores. However, we could not find a cutoff value for a low quality of life score that meant unacceptable outcome. We saw that there were patients who have very severe disabilities or even low quality of life scores that thought their outcome was acceptable. And this is found in earlier studies as well. There's a study who asked patients 6 months after ICU, how do you value your quality of life if you relate it to previously, before admission? And 1 in every 3 patients says, my quality of life has increased. So if we want to understand this apparent discrepancy, we have to look into 3 concepts. The first one is secondary gain. A secondary gain describes the benefit that comes with having a severe illness. And it's a concept that's been described in psychiatry a lot, but it holds for other persistent illnesses as well. It describes that your illness comes with a benefit. For example, a patient being unemployed before admission, now after admission suffers from a physical disability, which makes him be financially compensated by the government. And his or her overall situation might be improved by being financially sound now. So that's one. Second is the disability paradox. And this describes the paradox between having a severe illness or a disability and on the other hand, rating your life as good or excellent. And that's something that has been described in spinal cord lesion patients who might suffer from tetraplegia and still find their lives worthwhile and rate their quality of life as good or excellent. And this means that quality of life is more than just a disability. It reflects a balance of body and mind within the context, a social context, environmental context. So it's more than just the disability. The third phenomenon you have to understand is the response shift. And you might not know the term, but you know when I explain it to you. It means that when you have survived a critical illness, you appreciate things differently. You find a way to adjust to your disabilities and give meaning to it. So you have a different set of internal values and standards afterwards than you had before. So think of a patient, or think of yourself. You might not be very happy in doing your household, or vacuum cleaning yourself. You're never happy with that. Well, at least I'm not. But when you have survived a critical illness, you were almost dead, and now you're finally, after rehabilitation, you're back home and you're able to do your vacuum cleaning yourself. You might be happy with that. So internal standard, well, it differed. It's different now. And this response shift is also very important to understand or acknowledge when you do quality of life research. Because the pre-morbid quality of life, if you ask patients now, 1 year after discharge, to rate their quality of life before the ICU admission, that will be completely different than when you've asked them at that time point. Because when you ask them now, they will value their quality of life before the ICU admission with their new internal values and standards. So you have to acknowledge that when you do research. So it's apparent that the quality of life has not decreased, but when you ask them the then question, that's what they use for this kind of research, how would you have rated your quality of life before? If we ask you now, then I would give it a 9 instead of a 7, which I probably would have answered a couple of months ago. So these 3 concepts are very important when thinking of quality of life and appraisal of post-intensive care syndrome patients. So coming back to that schedule again, I think it's important to realize that there are all kinds of factors that influence how a patient appraises his or her life after ICU. It's environment or social factors. If you're a single mom having to take care of 3 kids and being not capable of it, that's very different than having a large family taking care of you. Your personality. If you've always been a very positive person, or you've always been a glass half empty person, that might differ how you are able to cope with your disease. Resilience is very important. How resilient are you to give a new meaning to your life? Coping style differs. Do you have a cognitive or emotional coping style? And is that coping style really helping you to cope with what you have to deal with? Religion might help patients, but also being able to regain work. Maybe not your previous job, but maybe another job, or maybe at least something that gives meaning to your life. So these are all factors we have to think of when we try to appraise or maybe even predict quality of life after ICU. So what do you have to do with this? Well, firstly, I think, sure, you have to know the facts, but you also have to realize that it's very individually how a patient will appraise his or her life 1 year afterwards. And actually, it makes me a bit more humble in decision making, because it's very hard to predict if this patient will be able to cope with the disabilities he or she might suffer from. So when trying to help patients in decision making, we should be aware of all those factors. And we might even have to try to get to know the patient a bit more and get to know the social environment and the personality. And I know it's hard because we don't have that much time for those family conversations. Second, I think it's important to realize that it might be a way of influencing outcome as well. So, of course, we have to try to minimize the effects of ICU admission on long-term outcome and on disabilities. But this is also a way to help patients deal with their disabilities. Maybe mindfulness training, learning patients a new coping style, building on resilience. That also be very helpful strategies to make people appraise their life better than they would do now. So, at the risk of being very cheesy, I'm going to end with an Albert Einstein quote, which is, "Not everything that counts can be counted, and not everything that can be counted counts." Thank you.